Good afternoon, everybody. I'm thankful to Dr. Namrata Sharma and the organizers for giving me this instruction course. Today's our instruction course is based on the IOL power calculation. What are the advancements happening in the IOL power calculations? So many formulas are coming up over a period of time. Every monthly there is a new formula which is coming up, and everybody is claiming that they are much perfect than the previous one. So we will go for that part, different the formulas, the understanding about the toric power calculations and toric calculators which are newly introduced, some basic and some advancements. Newer equipments are coming up, like different biometers are coming up in the market. Every 3 monthly there is a new optical biometer. So we are going for that part also. So we have a very esteemed faculty. We have a CNMOS Dr. Tejas Shah. Everybody knows him. There is no need to introduce him. He is a director of Ahmedabad Eye Laser Hospitals. Dr. Harshul Tak is a consultant at Jaipur. Everybody knows him. Dr. Shail Vasavada. Everybody know him as one of the pioneer in the cataract and refractive cataract surgeries. Dr. Vasavada's institute is very well known for that. So here we begin our journey with our first talk. My first talk is understanding the next generation of IOL power calculation formulas and its implication in the practice. So many formulas. We will first go for the understanding about how these formulas have been evolved, how we can classify it, and how we can utilize these all formulas in our practice. So in 2000, there was a good visual outcome was our main concern, and over a period of time from good to excellent, and now it is going to be beyond excellent effective, because each and every patient don't want 6/6. They want something extra vision from their surgery. So science progressing on the IOL power calculation, like advancing in imaging devices, newer IOL power calculation formulas, software for the data integrations, and some post-operative refraction adjustments. So the last part here, component is majorly taken care by the artificial intelligence. Advancing in imaging devices will be taken care by the Dr. Harshul. I am just focusing on the newer IOL power calculation formulas. Initially, when these IOL power calculation formulas were evolving, we were considering as a first generation or second generation, third generation. So in that way, it was increasing. But it was a little bit confusing, because only the Gaussian optic was only play in the initial phase. But as the ray tracing optics has been evolved and better understanding of the optical part on the ray tracing, these formulas are merging up. And lastly, the artificial intelligence also took part in that formation. So it becomes now more and more merging. So Dr. Douglas Cook in 2017 come with the classification for that, the historical refraction base or the SRK and SRK2. Nowadays we are not using it, but all based on the Vergen's formula, like based on the Gaussian optics. And majority of them at initial phase, it was only thin base lens formulas, and they were considering different variables. Initial all third generation formulas were considering the axial length and the keratometry. Over the period of time, Dr. Higgs come with the concept of anterior chamber depth. So it was a third variable, and the Dr. Barrett come with the two more variable like white to white calculations and the lens thickness calculations. So it becomes a usage of more variables, and Dr. Olade come with the concept of the age of the patient or the reflection of the patient. So more variables are started using in the consideration of the effective lens position calculation. So even though it was more confusing, so recently Filomena Ribeiro has classified these formulas in a conceptual classification. So what initially it was a data driven, and at present scenario also there is a data driven. Initially all the data driven was on regression based. Now all our data driven is on artificial base, AI based. So BART, Clark, Fulmonte, Hill RBF, LADA super formula, all these formulas are coming up with the artificial intelligence. Now problem with this AI is, because it is only a database, AI do not know about the biology of the eye. AI do not know about how these optics are working in a regular manner. Suppose your pupil is dynamic phenomena, that is not been considered by the AI. So all these factors are not considered by the AI. So we cannot solely go on the AI, because otherwise AI will give us erroneous results. So we have to control the AI. So we have to use the AI at a certain particular part of the calculations. We cannot use it as a regular, solely based on the AI. Another way, our theoretical optics Consider the optical approach, the Gaussian optics, the thin-lens based formula and the thick-lens based formula. Thin-lens based formula also again I divide into two parts. The older generation, third generation formulas, SRKT, Olade2, Offer-Q, Higgs, and the newer generation formula like CAN, Panacea, Kastov, Offer-QST and VRFG. And the thick-lens based formula, which is actually one should go for the thick-lens based formulas that are the Barrett, EVO, Pearl DGS, Nizar. So these are the optical approach for the Gaussian optics. And we considering the ray tracing optics, it can be Equilix or Olson or CSO. So this is the way it has been classified, but it cannot be classified in that way also because there is intermingling. So actually the classification would be like this, that the thin lens, thick lens and ray tracing, either they are regression incorporation or the AI incorporation, in that way we have to classify. But even though it is not classifying in a much properly. So again, Dr. Samini come in our help, and he has just recently introduced this new classification. It looks like a very large, but it is not very large. I can just explain very briefly. It has again divided into the versions, EI and the ray tracing part. The versions, again thin lens based formula or the thick lens based formula. In thin lens, the old generations like all AI, third generation formulas offer Holade, SRKT and Higgs. And the non-AI, which is a newer one, Castrop, Cook 6, Panacea, T2. T2 is a newer version of the SRKT. It is a very good formula for the majority of the eyes. The only problem with it, it is on Excel format, so you cannot further evolve for that part. And the VRF, which has been recently introduced by the Ukrainians. So these formulas have works a little bit better than the older general formulas. And when these formulas has incorporated with the AI, then the Offer QST, which is recently introduced by the Offer, because the Offer Q was working very well for the short eyes. Dr. Jesus will take that part, how we'll go for the short eyes. But the Offer QST, the Offer and the Savini and Terini, all this started a new formula, that is Offer QST. Then the CAN and Australian, he has also given a very good formula. It's a nearly same like Barrett formula, but it's a more incorporation of the theoretical optics and the AI and the LADA super formula. So all these thin lens formula which has incorporation of the AI, they works very well at present. The ideal optics, a thick lens based formula on the virgin optics. Non-AI is the Nizar 2. It has been recently published 2 years back. It works very well in the majority of the hands. The only problem is the same like T2 formula. It is also on the Excel sheet, so you are not going to evolve further. The AI-based thick lens based formula, EVO20 and version 2.0 and the Pearl DGS. And now all the AI incorporated versions are taking place in the popularity, whether it is a thin lens or the thick lens. Sole AI, as I had told before, we should not rely on the Sole AI, but even though Hill RPF is working very well, Carmona has recently introduced, it is now available online, but we don't know about the long-term results. Dallas Sami is still in publication. Now we go for the ray tracing one. It is a ray paraxial or the axial one. Again, there is non-AI or AI, Barrett 1, O formula, Olson formula, VRFG formula, which is incorporating more and more variables. They are considering 8 variables. And ZCalc. ZCalc is a formula which is available only with the JICE machines. And that works very well as far as, even though it is non-AI. And JICE come with another AI, that is JICE AI IOL calculator. The last paper they have submitted, they are claiming about the 93 to 94% over the whole range of the eyes. But the problem is still it is not commercial available. The central ray tracing, that is a non-AI, CS and Oculix, which is there since 7 to 8 years in the market. So huge classification. But what at present used by the general population, what we are getting, this study shows that we can obtain up to 90% of the eyes with the prediction error plus or minus 0.5, and it is our aim to remain under plus or minus 0.5. So all these formulas which has been on the left side of the table, all they are giving nearly 85, 88, 90, 91, up to reach up to 90 level, 90%. So why we are lacking? Why we are not giving the 100% even though so many formulas are coming up? The problem is the source of error in magnitude of IOL power calculation is effective lens position. So at present scenario, the 76% of the problem which is still with the effective lens position calculation. And the remaining are the excellent error or keratometry error or other factors. Even though we are increasing the more variables of the keratometry like asphericity. We are considering the keratometric index in the formulas. So we are trying to betterment for the keratometry part. As far as axis length is concerned, we have some adjustment in the axis length for the longer eyes. Dr. Tejas will take that part also, how we are adjusting by the Wong modification, and the newer optical biometry like the segmental biometry. All these are taking, emerging up for the development of the IOL power calculation formulas. The least opened up part is the pupil size. Still, we are not considering the pupil size in IOL power calculation, but it is over the period of time going to be have a boom over the period of time once we have achieved the first three criteria to be fulfilled. And then lastly, IOL data factors, and that is very surprising element for us. I just briefly go from each of them. The effect lens position for the normal eyes, we know this, that the normal eyes all formulas where when there is abnormal eye, there is always a problem in the calculation of effect lens position. So all the formulas are using more and more variables, like some are using the lens thickness, some are using the white and white, some are incorporating the more variable like corneal asphericity or posterior anterior ratio. All these formulas are coming up with more and more variables to have a reaching up to 90% or 92% of the success rate over the period in all range of the eyes. So updated instruments, so many optical biometries are available. Dr. Harshul will take in detail about this updated instrument, but I just briefly saying that two new things which is very important for is excellent measurement is a segmental biometry. I think Dr. Harshul will take in detail, just I am briefing you that segmental biometry is biometry where we are considering the each and every individual tissue refractive index rather than considering a single refractive index of the eye. So the corneal refractive index, aqueous refractive index, lens refractive index, everything has been incorporated according to it is a sum of all segments, and that is SOS biometry. And all other gadgets which are giving a very good corneal power calculation, front cornea or the back cornea, that gives us a very good total keratometry. Only problem with us is the IOL data factor. Now the problem with ISO, what ISO has recommended the validity criteria, that is a range which is tolerance range, and tolerance range up to less than 15 diopter, it is plus or minus 0.3. Tolerance range from 15 to 25 diopter is plus 0.4. Now we are here fighting for 0.2, 0.3, and the ISO range is so wide that the lens is very difficult to find out the exact lens. And particularly in high hyperopic eyes where we are using 30 power, 32 power, the tolerance range is up to 1 diopter. So even though we are using the base formula, we are not getting the exact IOL power. Another problem with this, the physical or geometrical property of IOL is the limitation, is a proprietary element. So suppose Alcon lens or J&J lens, they are not giving the details about what is the geometry of the lens. So recently, all our stalwarts has given one publication special report that all surgeons, we need to know about the refractive index of the lens. We know the central thickness of the optic, what is the anterior posterior curvature of the IOL, what is the toricity on the front surface, what in the back surface, what is the exact wavefront Z4 correction level, aberration correction level, what is the exact angulation with the optic. Optical angulation is also different according to the power. Suppose your power is 15, the angulation of the same lens is different, and suppose your power is 25, angulation is different. So all these things we actually need to understand about this IOL power calculation, but we are not getting any details of any lenses because it is a propriety of the each and every individual company, and that is a big issue. So IOL power does not depend on the surgeons or the formulas. It also has some element we require from the manufacturer also. So these are the basics. Now we go for in the practicality. Which formula in 2024? So many formulas are there. So around the world, commonly used formulas are Barrett Universal 2, Ken formula, Hill RBF calculator, Olson, Offer QST. 3 recently introduced is the EVO formula, Pearl DGS, Betal formula. So the last 3 are the designed to sum up segment biometry. This is what I had told about before. But the most important part is without regular optimization, their performance is not superior than the traditional formulas. So practically, how to incorporate this formula in the practice? So ESR has here come to in our help. So there is a website of ESR IOL calculator. You put your all the data on this calculator, and that will give you, and they will give you each and every individual formulas results. So that is known as the web scraping technology. and they will go to each and every individual formulation on the available web, and they will give you results accordingly. Second, another good part is that even you can customize you can use your own constant for particular formula also. So that is very good part of this. So this is the way it gives the results. And suppose I am getting this result. Now important part, which formula you will use? Because somebody is giving plus 0.16, some is giving minus 0.12. So you have to select the IOL power, whether you want to go for the 23.5 or 24. Let's understand this. We have to develop the strategy to choose the ideal IOL power. For that, I am taking an example. This is a myopic patient having a 25.21 is the axial length. And I put this data in the calculator and I am giving this result. So this is the 16 diopter has a valuation in the range of plus 0.17 to plus 0.06. If I will go to 16.5, then it will range from 0.15 to minus 0.26. Because it is a myopic patient, I don't want to have any hyperopic element in this patient. I will definitely go for 16.5. So this is the way you have to customize. Suppose you have your preferential IOL formula. Suppose I am at present I would like to go for the upper QST and heel RBF for the short eyes. So I can go for that as a prioritizing for this. So this is the way you can choose your IOL power calculation. These are the latest evidences. Dr. Tejas will go in detail here regarding this. So to start a new optimization of new formulas, because we have now so many formulas there, so you start optimizing your own data, normal eyes, long eyes, very long and short eyes. After 20 to 30, each data set you can optimize all these formulas to our patients. So in summary, for the measurement, use optical biometry to minimize the measurement error. Use the new generation formula for all the patients. Nowadays, use the ACRS calculator and optimize it. Be ready for newer formula to coming up, but keep optimizing your constant regularly for your favorite formulas. Thanks for your attention. Any questions? I would like to invite Dr. Arshul Tak for the next one.
Yeah, thank you very much, Dr. Twinkle. So for including me in your course, we have been doing this course for many years now. It's wonderful to see everybody. So I'll be speaking on advances in optical biometry. Okay, right. So we all know that biometry is the practice of applying mathematics to biology. So broadly, biometry system, we all know they are either ultrasonic based or the optical biometer based. So A-scan ultrasound, it uses a sound wave frequency of 10 megahertz, which has accuracy of only 0.1 millimeters. So why do we use this high frequency? Because it has minimal depth of penetration, but excellent resolution for small ocular structures, which is better for eye. But limitations of ultrasound A-scan, we all know, is that it does not depend on patient fixation like optical biometer. So whenever we are doing optical biometry, patient is fixating himself. So we are taking all measurements along visual axis. That is what we want in if we want to have a perfect axial length. Whereas in ultrasound, it's not like this. We are just measuring along this optical axis. Second problem is that ultrasound biometry, it measures till from the internal limiting membrane that is in front of the retina. But actual measurements we need from RP level, so that is what optical biometer does. So ultrasound biometer, they just measure till internal limiting membrane and take assumption that of average retinal thickness from 100 to 300 micron, and they add to it and they give the result. So we never have accurate results. So that's where these are two differences where optical biometer, we all know, scores over ultrasound A-scan, and why we should all shift to optical biometers. Then secondly, we all know that if you are using ultrasound, of course you have to go for immersion biometry. Contact is of course a big no, because indentation role always comes in when we are doing applanation biometry. So coming to can I have the pointer please? Audio visual? He's busy. Okay, so coming to the principle of optical biometry, so they're all based on, the mouse is not working. So they're all based on principle of laser interferometry. So this is the principle of pointer. This is the principle of Michelson interferometer. So what happens is there's a source of light which when passed through a beam splitter, it divides the light into two paths. And once the light come back again, so there is a detector. So there is a detector there. So this is the source of light which gets splitted by beam splitter. And both the light travels back, and then this detector detects the length of the light which has traveled, the path which it has traveled, and then gives us the axial length. So this is the basic principle which you have learned in physics. So just to make it more understanding that what are different biometers and how the waves are used in this. So if we look at the SSOCT and SDOCT, so these are the waves which are out of phase, but they have, and also they have variable phase difference. So these kind of waves, they are used in the newer SSOCTs. So this is the spectral domain OCT, and this is the SS swept source OCT, which is optical biometer 700, which is based on. So the first biometer, optical biometer, which was there was the IOL Master 500. In 90s, it was launched. It was based on the principle of partial coherence interferometry. So, and it used a 780 nanometer multimodal luminescent diode. But the limitation was, till 90s to 2000, limitation was, of course, it became gold standard because it gave accurate axial length, but limitation was only optically, it was measuring axial length, ACD and lens thickness, everything it was giving based on slit scan, not optically measured. So then came Lenstar 900, which was based on optical low coherence reflectometry. So, and it used 820 nanometer superluminescent diode. So optically it was measuring all the parameters which we wanted, like axial length, CCT, ACD, and lens thickness. So that's how they developed. And K readings, they were analyzed from the anterior corneal curvature at 32 reference points, which were oriented in two circles and at the 1.65 and 2.5 millimeter optical zone. So keratometry also became better, and all the parameters we were deriving, because as Dr. Twinkle mentioned, as the formulas advanced, we needed all these parameters to feed in those formulas. And these biometers, they were giving us better results. So this is the basic difference. PCI, which is optical, this biometer 500, which has a dual beam setup, and OLCR has a rotating glass cube system. This is a patented system of these biometers. So after that came AL scan, which was again based on partial coherence interferometry. So different principles were used in different instruments. Then came Aladdin, which was again based on optical low coherence interferometry. So till now, the limitations with these instruments, so axial length was taken care of, all parameters were taken care of, but limitation in these instruments were penetration in dense cataracts. So they were not able to penetrate through posterior subcapsular dense cataract or mature cataracts or like that. And they only measured anterior corneal curvature. So then came the newer generations of swept source OCTs, which we have now. We have IOL Master 700, which is based on swept source OCT. So why it's called swept source? Because wavelength varies from 1035 to 1095. As I showed there in swept source, this wavelength, it varies. It does scanning at rate of 2000 scan per second. And so if we have a look at this, so these are the 2000 scans which are taken per second. It scans at 0, 30, 60, 90, 120 and 150 degree axis. So it gives an image like this. So you can see OCT right from front of the cornea to the back. You can check for the foveal fixation, whether if you see a good pit there, it means fixation is good. Then what does it have is it has a telecentric keratometry, that is when you take a keratometry measurement, it's independent of the distance from the instrument, so that you never have unreliable readings. And it does 3-zone keratometry. At all these spots, they were taken at 1.5, inner one, 2.5 and 3.5, and 6 spots in each zone. So this is a 3-zone keratometry. And another thing which it does is it gives us the total keratometry. It measures, because it has OCT incorporated in it, so we can get the total keratometric value. And it does have the formulas which are based on total keratometry, like Barrett TK Universal 2 for normal eyes, Barrett TK Toric for toric IOLs, and Barrett True K with TK for post refractive surgery eyes. So as I said, and another thing which it has incorporated is the Chang varying chord, which is equivalent to angle kappa, which is angle distance between visual axis and pupillary axis. So if you see here, it gives Chang varying chord here, it gives 0.8 millimeters. So for all surgeons, they love to do trifocal and these lenses if it is less than 0.5. So it states away give these readings. So next, swept source OCT, which is I'm personally using, is a OA2000, which is manufactured by Tomy. It is also based on swept source OCT, and it has a scanning rate of 1250 scans per second, uses 1060 nanometer wavelength. It also gives all these measurements, and it has a Placido disc, which has 9 rings in it. So now Lenstar has also incorporated T-cone keratometry along with this. Then again, other biometer is Argos, which is again based on swept source OCT, and the newer one is Anterion, which is from Heidelberg. So these are the various newer biometers which are based on swept source OCT. They give better and reliable measurements as compared to the previous one, and they're able to penetrate through denser cataracts. So they increase the usability of these biometers in our Indian population at least. So to conclude, these biometers, they provide repeatable and reproducible measurements and different ocular parameters. They are effective obtaining biometry measurement in eyes with denser cataracts. And now optical biometry is, of course, the gold standard for measuring all ocular parameters and IOL calculations. Thank you very much. Okay. Thank you.
So, Dr. Arshul, what is your choice?
So, personally, I've been using OA2000
Yes,
swept source based OCT for last 10 years now. That was a,
So if
and
you
it
have
has
to
very
change-
good penetration.
If you have to change your optical biometer, what would be your next choice?
No, I would not like to change, because this has all the features which are required. No, it is based on swept source OCT. It has amazing penetration in denser cataracts.
And do you think Argos has a huge advantage over the previous ones?
No, I think I place 700, Argos, Anterion, OA2000. They all are same. They give the, and of course 700 has advantage that it gives true K readings also, which this doesn't give.
Yes.
But there is studies have also shown that clinically and practically results, nothing much to gain if you use even the TK formulas compared to the normal universal Barrett 2 formulas.
I think that's a very nice take-home message. Thank you.
I am also using the OA2000, but are you happy with the keratometry which OA2000 is giving you?
Yeah, of course.
Okay, very good afternoon. Thank you to Dr. Twinkle Shah for organizing this course, very important course every year, and making me a part of it. So I'll be sharing some of the things that we have learned over the years in power calculation with abnormal corneas. We do receive research grant support from Alcon Laboratories. Now, what are abnormal corneas? I think grossly we can classify them into 2 types. One is those who have had previous refractive surgery, and the second are those who have some sort of ectatic disease, most commonly keratoconus, but it could also be post-LASIK ectasia or pellucid marginal degeneration, so on and so forth. Challenges that we face in eyes with previous refractive surgery, most important is IOL power calculation, second is the type of IOL, and the third are of course surgical challenges that we face. To understand some of the basics of why they are different is when there is a normal cornea, we all have positive spherical aberrations, which means that the rays at the periphery bend more than the rays at the center. When we do a myopic LASIK, that would mean that we are flattening the central part even further, which means the positive spherical aberrations will actually increase because relative to the center, the periphery will become further more steep. And therefore, if a patient has undergone a myopic LASIK, you would rather have an aspheric IOL, which means an IOL with negative spherical aberrations rather than the one with a spherical IOL with a positive spherical aberrations. Compare that to a hyperopic refractive surgery being done. In hyperopic refractive surgery, we are steepening the center, which means the periphery becomes relatively flatter to the center, which means there's an increase in the negative spherical aberrations. That would typically mean that if a patient has undergone hyperopic LASIK, you should tend to choose a spherical IOL over an aspheric IOL. Post-RK can be anything. It can be good 4-cut RK to zillion-cut RK with corneal scars, and it's very difficult to give one conclusion based on that. Now, why is power calculation in post-refractive surgery as different or challenging is because the ratio of the anterior and posterior corneal curvature is changed. So there is normally a fixed ratio between the curvature of the anterior and the posterior cornea. Whenever a refractive surgery is done, this ratio changes. This either becomes flat or more steep, but the posterior cornea doesn't change. So the ratio symmetrically. So the ratio changes. And therefore, the conventional formulas, which are based on a fixed ratio of the anterior and posterior corneal curvature, do not work very accurately. So we need different special formulas. Now we saw so many instruments, so many techniques, so many technology, and if you go to the trade, I think I'll find 5 or 6 more other newer technologies. Which are the instruments that should be used as far as measurement goes? So I think the consensus definitely is that if you have a good optical biometry, even for measuring the cornea, they are extremely useful and extremely good in giving good power calculations even as far as the corneal measurements go. So I think having an optical biometry definitely gives us an edge in eyes with abnormal corneas and IOL power calculations. I think these are some of the eyes where probably doing a second investigation and looking for the regularity of the cornea can also be important. So for a routine case, non-refractive surgery eye, virgin eye, I think if you find clinically everything is normal, you need not do a topography or a pentacam for IOL power calculation or for toric calculation. But in eyes which have undergone previous corneal surgeries, I think it's important to look at the corneal surface, either just a topography or a Scheimpflug based investigation to look whether the difference in the K1, K2 is actually regular or irregular, because only if it is regular astigmatism can we consider a toric IOL. If it's an irregular astigmatism, irrespective of the magnitude, we should avoid any form of toric IOL. What formula to use? And I think the easiest option is to go to the until for so many years it was the ASCRS website. Now also the ESCRS has its own online calculator for post-refractive surgery eyes. So basically you go onto the website, it's a free formula, and choose what kind of prior refractive surgery has been done, whether it's an RK, hyperopic LASIK or a myopic LASIK. And based on the number of data inputs that you will give with the number of machines that you have, you will get the calculations done by the different formulas that are there. And out of all of that, it will also give you a minimum, maximum, and an average of all the formulas. So it allows you to pick and choose. And if you have any 1 or 2 favorite formulas to go to, you can go closer to picking a formula based on the calculation there. So out of these several ones, which all should we use? And unfortunately or fortunately, literature is relatively sort of divided until a very long time. Now most of the studies have shown that the Barrett True K, which is not the Barrett Universal, the Barrett True K, which is designed for post-refractive surgery eyes, seems to be working as well or as bad as most of the other formulas as far as achieving eyes within plus or minus 1 diopter of the targeted refraction. So for a normal myopic or a hyperopic refractive surgery, for at least for us, the Barrett's True K formula is something that we rely on more often than not. We actually did our own study, which we published 3 years back, where we compared the different formulas in patients undergoing corneal refractive surgery, that is LASIK PRK, as well as RK. And what we found was that in the post-LASIK eyes, the minimum when you choose showed the maximum when you out of the ASCRS calculator, the minimum average and the maximum. When we chose the minimum, we had the maximum number of eyes within plus or minus 1 diopter. Whereas in the post-RK eyes, when we chose the average of the ASCRS calculator, we had the maximum number of eyes in the plus or minus 1 diopter. But like I said, RK is still, it's very much on a case-to-case basis that we need to consider. What is the role of measuring the posterior corneal curvature? The discussion that we just had. And there are now machines which allow us to measure the posterior cornea directly, like the Scheimpflug imaging or the Pentacam or the Galilei. And there are biometers which actually don't measure the posterior cornea. The IOL Master 700 also gives you a simulated posterior corneal reading, not the direct capture reading. But yes, you do have now readings of the posterior cornea that are available. So when you go online and go to the Barrett's formula, you have this 2 options. The default is the predicted PCA, which means that the patient, the formula has decided a fixed algorithm based on the anterior corneal curvature that you'll add. But if you want to add your own posterior corneal values, you can just switch the mode to measured PCA and enter the values. As we discussed recently, just before this talk, all of the studies so far have shown that in a virgin normal eye, it doesn't matter whether you use the posterior cornea or not. Very 1 or 2 publications are now starting to come up, which are starting to show that when you use the total keratometry with the IOL Master 700, there are more chances that you get more patients within plus or minus 0.5 diopter using the total keratometry compared to without using the total keratometry. And in fact, we have been part of a multi-center study which is now in peer review publication, and I can share that actually we found equal number of eyes within plus or minus 1 and equal number of eyes within plus or minus 0.5 diopters with or without the posterior K. The only difference or the only advantage the posterior K gave was that the predicted error was more accurate with the posterior K than without using the posterior K. So it may add a slight edge in special eyes, but it's not a deal breaker measuring the posterior cornea. I think the other challenge is in eyes with post-RK. One is the calculation, but also is second the incisions and the gaping of the incision. So you may have to do scleral incisions like in this eye with so many cuts. Therefore, your SIA may be very differently. In eyes like this with good gap, you can do incisions between the gaps and you can get away. But in spite of all possible, care taken, very often you may end up with gaping of the wounds, which you may need to suture, and all your astigmatism calculation and IOL power calculation can go haywire. So particularly in post-RK eyes, do tell them that you need to be careful. This is an interesting patient, a patient with a thick vascularized recurrent pterygium, absolutely refuses pterygium surgery, that is not interested in a repeat pterygium surgery, has a significant cataract and as you can see, not a very well dilating pupil. And if you see, there are a lot of irregular aberrations coming from the cornea due to the pterygium. But if we actually zoom in to this dotted zone, which is the actual mesopic pupil capture of the patient, you'll see that there is a regular bow tie appearance in this pupillary zone that the patient has. So although the patient has significant pterygium, we did counsel him for a toric IOL, and the patient did very well post-operatively with a very minimal residual error left behind. Keratoconus, coming to keratoconus or ectatic disorders. Keratoconus is a term I'm broadly using for ectatic disorders. Unfortunately, there is no consensus. And the reason is it's a very variable disease. It depends on the severity of the keratoconus, the location of the cone, and therefore literature is limited. We don't know, there's a lot of debate on what keratometry to rely on. Should we rely on a more central keratometry? Should we rely on the mid-peripheral keratometry? What is the true actual anterior chamber depth because of the corneal thinning, and therefore the effective lens position? And most of the formulas I've shown to give hyperopic outcomes as far as keratoconus goes. So there are now number of publications coming up. I'm just sharing one of them, which is a review which compares the different IOL power calculation formulas in keratoconus. And unfortunately, all of them give different answers. And most of them have shown, the review in the end concludes that most of the studies have shown that in keratoconus, the SRK-T yielded the best outcomes, even better than the third generation and the Barrett Universal 2. And that's probably because it uses the least number of parameters for IOL power calculation. Of course, there are newer formulas which are under peer review, but unfortunately, because it's not such a common disease, we still really don't have a go-to formula as far as keratoconus goes. But I think the newer formulas like the cane and the keratoconus mode in the Barrett's Universal 2 should help us to improve it in these cases. I'll just share one case of a known case of keratoconus diagnosed after her first pregnancy. Presented to us with cataract and never used contact lenses, was managing with glasses with high astigmatism. And when we looked at her pentacam, there is, as you can see in her mesopic pupil, there is reasonable regularity of the astigmatism. The right eye is relatively better compared to the left eye. And you can see more than 5 diopters of astigmatism measured in both eyes. When we did the IOL power calculations, one using the Barrett's keratoconus mode, it showed even with the maximum powers that we had to use, we will be left behind with about 2 or 3 diopters of astigmatism. And again, if you notice here, KC mode, which means the keratoconus mode in the Barrett's 2K formula, suggested somewhere between 11.5, 12, 12.5 and 14.5 to 15.5 in the left eye. So we counseled the patient 2-3 times that we don't know what the refraction would be post-operatively, and we went ahead with a 12 diopter T9 first myopic target and 14.5 in the other eye, the first myopic target. And fortunately, we were reasonably on target. The patient ended up with a +1 in the right eye with a -2 cylinder and only with astigmatism in the left eye. And she's extremely happy and she's accepting glasses is quite well. So I think to summarize, there are multiple challenges in abnormal corneas, calculating, measuring what kind of IOL. Post-LASIK and post-PRK calculations have now become quite predictable and reliable, almost as good as our normal eyes. But I think post-RKs and keratoconus or ectatic disorders continue to remain a challenge. Thank you so much for the patient listening.
Thank you, Dr. Shail. I would like to invite Dr. Tejas for his presentation about the power calculation in abnormal situations, very long eyes, short eyes, post-vitrectomy.
Good afternoon. Good afternoon, one and all. Am I audible? I'm just making sure you guys don't go to sleep, because if you want to sleep, the auditorium is a better place. It is cool, dark, and quite mood lights are there. Well, so let's, after listening to the types of formulae that we have available, Dr. Alshul talking about the optical biometers that we should be using, and then Dr. Shell talking about the abnormal eyes. I'm going to talk about long and short eyes as well as the vitrectomized eyes. I might be skipping the busy slides because time is pressing. So when do we classify it as a long eye? More than 24.5 millimeters. These are some basic slides. And what are the errors that we can get? The measurement error and the formula error. What actually is the problem with a very high myopia? Well, the axial measurement has following problems, like a fixation issue, especially with a post-staphyloma, and there are so many anatomical variations that a straight beam of line with, with a non-optical is also going to be a huge problem. And so to overcome these issues, we have the optical biometry. Like Harshul explained to you, it measures right at the RP level. What could be the measurement errors? Well, vitreous liquefaction in eyes with axial myopia. What does it actually lead to? Well, we have refractive index of vitreous, which is segmental and it is different, right? Because of the liquefaction in the pockets. And hence the gold standard refractive index is no more accurate. We are understanding more and more about this vitreous also. It leads to overestimation of the axial length, and you can understand that overestimation of axial length leads to a lower power, and because of that we will have a hyperopic surprise, which is the first thing we should never have. Well, none of the cataract surgery should end up with a hyperopia. I believe everybody agrees to that. Came the Van Gogh formulas for adjusting the axial length in eyes which are more than 25.2 millimeters. I'm going to explain more in the next few slides. And these are the formulas which started incorporating them with a different pair of A constants also. Then there was a Van Gogh adjustment also. Why was it? To compensate the overestimation of the axial length. They adjust, or in short reduces the axial length by formula specific coefficient. Holiday works better up to axial length which are more than 26.5, and the SRKT works better with the axial length of more than 27 millimeters. And when I say SRKT, it is the SRKT with the Van Gogh adjustment, not the SRKT which was there in our old our biometers. It is quite an aggressive method, gives surprises of myopic error, and hence came one more change in the entire thinking, and the ULIP modified and re-optimized formulae in the website came into place. What did the ULIP do? Let's see that. Yes, very important is all these formulas do not use in refractive surgery eyes. So the Van Gogh adjustment, the new one with the ULIP also came out with certain parameters, and they found out that the Holiday optimized was better for 26.5 and SRKT was better for 27 millimeters and above. I mentioned about the liquefied vitreous. Well, so this is one instrument which is going to be helpful when your liquefied vitreous has different refractive indices, correct? And this is Argos allows you to measure in spite of different, because it sums up all the refractive indices of the vitreous cavity. So special formulas for SOS biometry, the Barrett true axial length or the BTOL is especially for the segmental biometries, the Pearl DGS and the EVO formula. I'm not sure how many of these are going to be commercially viable for us. I'm going to skip this because this is for the long eyes, that the Olsen, the Barrett and the Haggis were the top three options. Not going to. So trying to conclude, long eyes formulas which to use, well, Barrett, Kane, Hill RBF and Olsen, which are quite easily available. They work very well in all lengths of long eyes. If you want to use the third generation formula, you can go for ULIP Van Gogh modified Holiday 1 for 26.5 and ULIP Van Gogh modified SRKT for more than 27. Newer modifications of Holiday NLR for high myopia also gives better performance. Well, but this is like choosing which phone when you go to a store or which sari that you want to actually buy. In summary, optical biometer, it overperforms the immersion biometry. The newer SOS biometry is an emerging concept, and Kane, Barrett, Hill RBF versions, Hill version 3 works very well, and for third generation formula, use only ULIP modified Van Gogh adjustment. So let's talk about the short eyes. Classification of short eyes, less than 22 millimeters of axial length. What are the problems? The axial position of IOL now becomes very important. The effective lens position. High power IOL, small shift in position leaves a big impact. I will describe that in the next few slides. 1 millimeter shift of effective lens position affects to about 2.75 diopters of spectacle powers for an IOL, which is about 34 diopters, and it changes when it becomes 40 and 45. The shape factor and IOL design are also very important. So this is no longer the purview of our IOL power calculation. It's the IOL design, and the IOL power makes the difference in our IOL power calculation. high degree of spherical aberration in higher power spherical IOLs, well, you can understand a thick bulging IOL is definitely going to leave behind a lot of spherical aberrations. So in spite of a 6/9 or a 6/12 vision, the patient is not happy optically. A small example of the axial length and how it impacts, well, error in an axial length measurement which have higher impact in the short eyes, like I said, in an average eye, 1 millimeter of axial corneal compression will give about 2.5 diopters, but the same thing will be about 4 diopters in a short eye. So which formulae for short eye? Well, Hofer Q. How many would use Hofer Q for a short eye? Everybody. Me also. Well, now listen to this, read this statement. Now it is an outdated concept. It was when third generation versions formulas were in use. And Dr. Warren Hill also says that for some reason it got stuck in everybody's head that you are supposed to use the Hofer Q, Holiday. One may be better, and few newer methods like Barrett and Hill RBF do even much better. So, which formulae for short eyes? Well, studies were conducted in 2016 by Kane and Mellers. And again, a very busy slide. They also came to the same conclusion that Hofer Q is one of the poorest formula for short eyes, which we have been using every day for 20 years. Correct? Barrett and Holiday 1 performed better in 21 and 22 millimeters of range. And this is a comparison between the Lenstar and the IOL Master and which formula to use with each of the machine. With Lenstar, it was Olsen and Barrett, and Olsen's CLCR is also again a different formula. It's too much to digest in 8 minutes. I will also skip this. And what is coming up for short eyes? Lens thickness. Well, it can improve the IOL position prediction when axial length and anterior chamber depth are also known. Newer swept source societies with lens tomography, modeling of crystal lens is also possible. And superimposing lens pre and post operative data will help in understanding of these problems. What should we do for short eyes now? Well, ray tracing works better, and oculics and phaco-optics are the formula which should be used. Barrett and Holiday should be avoided in short eyes. Haigis, Olsen and Hill RBF version 3.0 results are comparable, and newer Hofer QST, newer formula works equally good for small eyes. And what are the challenges of an extreme hyperopia? Well, if you end up with an IOL power of 40-45, well, you might actually not get the IOL company of the IOL company giving you that much power. You might have to have a piggyback IOL, and the piggyback IOL also has its own problems. So in summary, for short eyes, standard cases, Barrett Universal 2, Hill RBF version 3.0, Olsen and Holiday 1 or SRKT are the standard formula that we can use. For high myopes, Holiday 1 with Wangkok modification, Barrett Universal 2, Kane, Olsen and Hill RBF version 3 works well. For very long eyes, which is more than 27, the Barrett Universal 2 and the Hill RBF version 3 along with Kane. And for short eyes, again, ray tracing with LT, Olsen and Oculex, Hill RBF version 3.0, Hofer Q and Haigis, the optimized one, and the Barrett Universal 2. I am sure not everybody can afford to get all this in their clinic, but you can always go and send your such patients, which would be rare, to a clinic which has all the possibilities, to a neutral surgical center which has machines and this formula which are incorporated. So, coming to my last topic is the post-vitrectomized eyes. There can be two situations. Eyes without silicone oil. A patient would have undergone a vitrectomy, but no longer has silicone inside the eye, and this can be considered normal, and so you can go ahead with whatever you're doing. But the challenge is that eyes which have a silicone oil inside their eye, and here you have two important considerations. One is the axial length measurement. Please remember the refractive index of the vitreous has changed because of the silicone oil, and the IOL power and the model selection. So the eyes with no advanced or mature catheter optical biometry preferred over ultrasound. Well, in fact, this is an universal statement, but sometimes eye with gas, it blocks ultrasound, and so here also optical biometry. Though this is very rare because the gas usually is not a big problem, it goes away in 15 days. In silicone oil filled eyes, the sound travels slowly. 1515 milliseconds is a normal Fakey guys versus 1000 and various densities of silicon oil. So this is again another challenge. Your surgeon would have put 1000 CST or a 980 or a 5000 CST oil. And we do not actually have a data of different silicon oil densities giving us different for axial length measurements. So the low velocity with the silicon oil causes an erroneous measurement of vitreous cavity depth. The formula to correct axial length in any silicon oil vitreous is always incorporated in E-scan. I believe everybody knows that whenever you are trying to do a sonography of this type of patient, you select the mode which says silicon oil filled eyes. This is something very important. And the conversion factor of 0.71 multiplied by the measured axial length has been reported to correct for the apparent increase in axial length induced by silicon oil of viscosity of 1000 CST. There might be a small change if the viscosity is 5000 CST. Some other small tips are, well, if the eye is whether fully or incompletely filled with silicon oil, you can understand, it's common sense that if it's a incompletely filled eye and if you are doing the axial length measurement in sitting position, the silicon oil might not be actually in the path of your optical biometer, right? But it is always better to do it in sitting position. Some eyes impossible to measure. I will try and skip this slide. So silicon filled eyes, IOL power calculation, the high refractive index of silicon oil makes it behave like an intraocular meniscus minus lens. Therefore, without appropriate power adjustment, significant hyperopic overcorrection could be expected. Biconvex lenses have higher correction than plano-convex, though there are very few biconvex lenses available. And eyes with posterior meniscus also experience the smallest. So the rule of thumb is use a convex plano IOL, add 3 to the calculated IOL power. The challenge is the patient would have a silicon oil in the eye and it is going to be removed after 2 or 3 months. Well, so how do you adjust that? So you can add 3 or 4 diopters to that. If using a biconvex lens, add 5 diopters. And when silicon oil is removed, performed 3 to 5 diopters induced myopia should be expected. So the choice is silicon oil addition to, another problem is silicon oil addition to IOL surface is maximum with the silicon oil, IOLs. However, it can also occur with hydrophobic, acrylic, PMM and hydrophilic lenses, but in decreasing order and decreasing frequency. Avoid silicon IOL, plate haptics, all this is another topic. That's all. Thank you very much.
Very nice talk, Dr. Tejas sir. I invite Dr. Shail Vasavada for his last talk about the IOL power calculation in pediatric cataract surgery.
So I acknowledge the contribution of Dr. Deepa Agrawal in making this presentation, and we do receive research grant support from Alcon Laboratories. So the primary challenges are getting a good measurement in children, what formula to use, and the target refraction. In older children who are able to sit up and allow us measurements on a machine, obviously we go and calculate as we would do in an adult person, except for the target refraction. But majority of pediatric cataracts are, uncooperative, which is children less than 3 years of age. And therefore, they are likely to require examination under anesthesia, not just for IOL power calculations, but to actually also look at the eye, whether it's actually a cataract or a fetal vasculature, retina, conioscopy, glaucoma, so on and so forth. And if possible, the best way to measure the keratometry would be using handheld autokeratometers. And if you're unable to access that or unable to do that, if it's a relatively otherwise normal eye, you can also go for the standard case based on the age-matched normative database that have been published way back in 2008. So it's steeper when the child is younger, and it tends to become flatter as they grow by 3 to 4 years. It's always a better idea to measure the axial length with immersion biometry because contact can be inaccurate. The major challenge in children would be to get that bulky Prager shell inside the eye, because some of these eyes are very small. So you, like for example, we've got it customized, got that Prager shell made by a local manufacturer for different smaller sizes as well. But if possible, we must try and get an immersion axial length rather than a contact, because contact even in pediatric eyes has been shown to be significantly less accurate than the immersion biomicroscopy. The IOL power calculation formulas, unlike adults where we have 2 or 3 very good formulas which we can blindly rely on, children, the literature is completely divided, and that's because each pediatric eye is very different based on whether it's unilateral, bilateral, age of surgery, so on and so forth. So several papers have given several different options to consider. We've analyzed our own data which we published many years back, and we find in our hands the SRKT or the Holiday 2 seems to work the most accurate as far as pediatric eyes goes. In the target refraction, the main question is, should we undercorrect, and if yes, then how much? So the principle of undercorrection is that you may have a greater chance of getting amblyopia just now, but if you correct them well with spectacles, the chances of developing very high myopia when they grow up is much less. Whereas the theory for emetropia is, which means very little undercorrection, is less amblyopia now, but the chances of developing very high myopia after when they grow up is quite high. So the general consensus is to undercorrect, and how much to undercorrect for that age is a very important factor determining the rate of the axial length. And the maximum phase of axial length occurs in the very early phases, which means less than 1.5 to 2 years is the time when the axial length grows the most. And it's also more in children less than 1 year, and it's higher in pseudophakic eyes compared to aphakic eyes. And the rate of axial growth is higher in a unilateral pseudophakia, which means a unilateral pediatric cataract, compared to the normal non-operated eyes. So unfortunately, the eyes do behave little abnormally. So undercorrection is the key word, and it depends on the age of the child, laterality of the cataract, and whether the child is already myopic for the age or not. And there are several nomograms, the commonly used ones being the Trivedi and Wilson nomogram, where based on the age they have a fixed post-operative refraction which they target. Younger the child, 1 year plus 6 diopter, so on. So older the child grows, less the undercorrection, and typically around 7 to 8 years we stop undercorrecting very much. We've developed our own strategy with our own database, and this is something that we follow, that for very young children less than 6 months we undercorrect by 30 to 35%, and as they grow older we tend to undercorrect them lesser and lesser, and anything more than 6 or 7 years we hardly undercorrect them. So let's take this case for example. Age of surgery of this child was 4 months and 20 days, bilateral cataract, and had normal axial length for the age, 18.6 diopters in both eyes. So keeping that in mind, less than 6 months, so we did the calculation and did a 30% undercorrection. The emetropic power was 36, so 30% reduction would mean about a 26 diopter power which we implanted in both eyes of this patient. And this has been the child's refractive history from surgery until now, 5 years post-operatively, where he's left behind with very little hypermetropia, but there's been no great myopic shift, and present day vision with +1 and +0.75 hyperopia for distance is reasonably good. What about toric IOLs in children? I think toric IOLs can be considered. First of all, the child needs to be older than 5 years of age. So literature has shown that about between 5 to 7 years of age, the keratometry stabilizes. And then the major changes occur then only after 30, 35, 40 years of age. So we published this data on visual outcomes of toric IOLs in pediatric eyes undergoing cataract surgery, and it's the largest cohort of pediatric eyes with toric IOL published so far in the literature. And we found that definitely there is a significant reduction, a predictable reduction in the post-operative corneal astigmatism, lasting even up to 3 years, which was the follow-up published data. And they remain stable even with the posterior capsulorhexis or an intact posterior capsule. So they are effective in reducing astigmatism, particularly in older children. So I think, to summarize, it's difficult to measure in children. There is no consensus on the best IOL formula. But I think using the SRKT Holiday 2 is good enough. Do appropriate undercorrection as per the age and the laterality. But most important is that the treatment of pediatric cataract starts after the cataract surgery, unlike in adults that once you operate the surgery, everything is over. Here, the amblyopia therapy and glasses and lifelong follow-up is the most important treatment. Thank you so much.
Yeah. Excellent presentation as always, Dr. Shail. We invite Dr. Twinkle, our chief instructor, for the last part of this talk, which is toric IOL calculators, something very important.
Dr. Shail, you have told about the abnormal cornea. Would you like to go for any formulas which are corneal bypass formulas for the abnormal corneas, like post-RK having a 32 or more incisions?
So, to be honest, I haven't experimented much with the formulas. For the past, I would say more than 7 or 8 years, the Barrett's has been our go-to, including for refractive eyes like RK and things. And if it's an RK, I would, with whatever the Barrett shows, I would put 0.5 or at least 1 diopter more than what the Barrett shows, and it reasonably works well. But I haven't experimented too much with the different newer formulas.
Thank you. So we'll go for the last talk of the session. There are lots of toric calculators available these days, and how we can integrate these in our practice. Now, when we go for any toric calculator, we have two components. One is the spherical power component, which we are deriving from our formulas which we are opting for, and second is the axis and cylindrical power of the toric lenses. Now, if it is the same, then why we have so many toric calculators? We have so many toric calculators. Why it is happening? Because we have little bit understanding about the astigmatism part. So first is the SIA part, surgically induced astigmatism. There is some newer understanding about the posterior corneal astigmatism part. There are definitely influence of effect lens position of the cylinder at the corneal plane and cylinder at the IOL plane, and certain things like a postoperative IOL tilt factor. So we will briefly go through them, and then we'll go for which are the available toric calculators for us. So for the SIA, we all know that Dr. Warren has given us this website. You can calculate your own SIA value. But the problem with this SIA is the magnitude. Typically shows the wide variation. Dr. Tejas is operating from 180 degree with a 2.4 incision. He is getting the SIA of minus 0.32, and Dr. Shail is operating and he is getting minus 0.22. So there is a huge change in the wide variation in the magnitude. In the same way also in the orientation part also. Because of the better understanding with these vector analysis by the supercomputers, and we have a retracing technology and optical engineering system, that each and every point of the eye we can calculate about the correction on that part. So you apply this trigonometry and the vector analysis, and when we go for that, the average of these vectors represents the mean SIA value, and that is known as the centered value. So for the centered value, Dr. Douglas has given us a value of 0.1 for the 2.4 millimeter corneal incisions, or 0.12 for the 2.8 incisions. Another important part is to understand about the posterior corneal astigmatism. We all know that the cornea on the posterior surface acts as a strip vertically, so it is a negative lens. So the effect on the width rule on the front part, it has a decrease in the total corneal power in the back part. And if it is against the rule astigmatism, the net effect will be increased in the ATR valve. So for that, Dr. Barrett and others have given us a nomogram. So suppose your front cornea is like this, you have to add or subtract the according to their with the rule or against the rule. So we have so many nomograms available. Now so many machines are also available to measure the anterior cornea and the posterior cornea, like SSOCT based or pentacam based or intraoperative aberrometry like ORA or color LED patterns. So all these machines give us a very good idea about what is the total corneal power. Now we have estimation part, so many nomograms are available and so many measurement are available. So what we should do, and what the study says that the performance of the measured one or the estimated one are nearly similar. So there is no need to rush for buy the newer equipment for a total corneal power calculation is concerned. And this is another very landmark study which shows there is not a compatibility between the different machines. Suppose I am taking a corneal power of the pentacam and suppose I am taking a corneal power of IOL 700. Even though both are not the equivocal power, there is some variation between these two technologies. So that is again an issue for us for the consideration of the total corneal power. And another important to understand about the ELP effect influence on the cylindrical power. Usually all toric calculators initially will consider the fixed ratio. You want to correct the corneal power 1.5, then the IOL correction is around 2.25. The fixed ratio was considered as 1.45 to 1. But suppose you have a high myopic patient or a hyperopic patient, this ratio change. Rather than 1.45 to 1, it's converted to 1.2 or 1.75. In the same way, even if you have a flat cornea or even have a steep cornea, the corneal toricity ratio is changing. So you should have that consideration in your toric calculator that when you are going for that one. So which calculator one should use? When you are selecting the toric calculator which is using the centered value to represent the SIA value, calculator which incorporates the PCA automatically whether it is a predicted one or a measured one, calculator which is considering the variable toricity ratio which is inbuilt required, and lastly and foremost, it should calculate the spherical power using the advanced formula. Because whenever you go for any company's formula, suppose you are going with the Johnson toric calculator or you are going for the Alcon toric calculator, you have to get the spherical power from your optical biometry or your immersion scan. So actually you should have an incorporation of this kind of advanced formula in the toric calculator, so you don't have to get it from the other instruments or other versions, older versions. So we are going for the different calculator which is available at present is the Alcon toric calculator, which has another two beneficial about the Barrett and the Olade, and also it can give the predicted and the measured one also. The only problem is you have to get the spherical power from the other machine. The same way Barrett toric calculator which is available online freely, it also can be used as a nomogram base or the measured value. And another advantage of the Barrett toric calculator, you can have a mean of 3 different keratometries. Suppose you have 3 machines, you have a optical biometry, you have a pentacam or you have a auto-K. You can get a mean of all of 3 keratometries for the measurements. The Kane toric calculator which is very much popular nowadays, this is based on the theoretical optics which is also both the regression and AI based. This is very important to understand. When you are using the Kane formula, Dr. Kane has suggested use a SIA of the 0 when you are going for the temporal incidence less than 2.75. Usually we are putting our own SIA and then it will give a erroneous results. The next is the EVO toric calculator which is coming up very fast because it is a thick lens based formula. It has a incorporation of the SOS biometry, sum of segment biometry also, and it also takes an account of the lens toricity surface, whether your toric lens is the front toric or a bite toric or the posterior toric. It also take an account of this one, and it is also AI based also. So this is at present the most popularly accepted toric calculator, that is a EVO toric calculator. This is another toric calculator which is a Nazar and 7A toric calculator which also gives both the comparison simultaneously. It gives the keratometric predicted one and also you can measure, you put the measure one. So you have a simultaneous comparison of these toric results. So now so many calculators are there. What to use? Barrett with a predicted one or measured posterior corneal power or a AIOC or a Kane one. Again ESC has come here to our help. They are giving online 4 calculators, Barrett, EVO, Offer, QST and Kane. All these 4 calculators are available with us online with the same web sphere technology. You put your data, even you can optimize your personal A constant for that also, and you will get the results. And results will be like that. You have a spherical component, you have a cylindrical component, which axis you have to implant, and you can compare all 4 toric calculators at a time, at a stretch. And you can take a printout of these into your OR also. So, lastly, and least understand about the IOL tilt factor, which is coming up in the near future. So, in summary, instead of SIA value, use the centered value in the toric calculators. Total corneal power, either predicted or measured at present, is equivocal for all the cases. Use the toric calculator, which is incorporating centered value, PC estimation, variable toricity ratio, and inbuilt spherical IOL power calculation. And upcoming toric calculators are SOS-based biometry, total corneal measurement values. And nowadays, the calculators are coming up with the tilt factor. The Panacea came with the tilt factor consideration recently. Thanks for your attention. So here we come. Yeah, please.
Can we have the next set of speakers for the